Welcome to the mini lecture on physician-assisted suicide. I don't have too much to say here, and I didn't want to get into rational suicide too much. I thought Joyner did a great job in Myths About Suicide about rational suicide. So instead of reiterating everything he said, I thought I'd give you an update on physician-assisted suicide, because this is an area that's really changing minute by minute, really. It's very current, even though you don't hear about it too much anymore. So I thought I'd share with you what's going on and some facts about it that you may find interesting and hopefully help you form an opinion about it. It's a very controversial topic. For instance, the American Association of Suicidology has decided not to have a stance on whether or not physician-assisted suicide should be allowed. So you have your main suicide prevention group saying, we're not going to state an opinion one way or the other on this. So it's okay to have, whatever position you have is okay. I just want you to be informed about it. So there are actually now 5 states that allow physician-assisted suicide: Oregon, Washington, Vermont, New Mexico, and technically Montana. So Montana, it's not really going on, and what happened is there's a court ruling that opened the door for it, but there aren't all the statutes and protections that have been established in places like Oregon or Washington. So some of these are very new. Vermont, I believe, I think it was 2013, Vermont added their name to the list. New Mexico actually came on this year in 2014, and New Jersey will vote on it in August. So, as I mentioned, this is happening now. This is something that's currently evolving. Now, here are some of the requirements that are pretty consistent across states. I'm not saying that these are the requirements for every state. There are some differences, but just to give you an idea of what it looks like. So the person must be terminally ill and within 6 months of death. So the patient must be the one that initiates the request. And with this request, it actually, there must be 2 requests that are separated by at least 15 days. And some states also require a written request in addition to the 2 oral requests. So this isn't you just asked once. You have to ask many, many times. So any physician, pharmacist, or healthcare provider can refuse to participate. You don't have to do this. If you have a patient that wants to do this, you don't have to do this. Also, the request has to be confirmed by at least 2 witnesses. They can't be related. They can't be entitled to the person's estate. Of course, that could bias someone. One of them can't be the physician, and one cannot be employed by a healthcare facility that's caring for the patient. So you need at least 2 people confirming, witnessing these requests. So once the request is made, you have a second physician that examines the patient's record and confirms the diagnosis. So the patient must be deemed free of a mental condition that would impair judgment. Now, we'll talk about, it would make perfect sense that you'd probably want a psychiatrist or psychologist involved to make that determination. That rarely happens, but we'll get to that later on. And the patient, of course, has the right to rescind the request at any time. You can get the medications and never take it. And in fact, that's what often happens. So here's the data from Oregon. So these are from 1998 to 2013. And you can see how many people got the medications versus how many people died. So you can see that this has actually been increasing and is still increasing over the last several years. But the deaths are significantly lower, almost half of the number of requests. So many individuals will get the medications and either will die before their use or decide not to use them. And that's, of course, up to the patient. So, obviously, there are many states in play. I tried to grab data just from the ones that had the easiest data to get. So, Oregon really has tracked their program well. So, from 1997, when it started, to 2013, there have been 752 physician-assisted deaths in Oregon, versus 1,173 prescriptions written for it. Now, for the latest year, so in 2013, the median age was 71, but you can see the age ranged from 42 to 96. And these were rather well-educated individuals. About half had a bachelor's or higher, and a majority had cancer. This is actually a lower cancer rate than normal. In typical years, it's usually above 70%, but as you can see in 2013, there's a little bit below. Now, what dumbfounds me is in Oregon in 2013, only 3% of individuals were referred for a psychiatric or a psychological evaluation. So the individuals who are making the decision about whether or not the person's in the right frame of mind and free of mental disorder that would, block them from being able to make this decision, this is not being made by psychiatrists or psychologists. This is being made by individuals who are not mental health professionals, which scares me to death. There's actually an article that I read prepping this lecture that came out this year of a physician arguing that psychiatrists and psychologists should not be required to assess a patient, which obviously they aren't now. It just scares me. I can't. The argument was that many psychiatrists or psychologists feel that a person would not be sane if they're making this request or would not be of sound mind. But, some of that's, well, first of all, the people that have a moral stance against it don't have to take part in it. We already talked about that. But also some of that is from our training. I'm one that I think I'd be very hard-pressed to come up with a situation where I would argue that the individual is of sound mind if they're requesting physician-assisted suicide. But that's from what I know, and I've studied this a lot. And so if you're interested, ask me. I'll send you the article. You can read it and see what you think. But it dumbfounds me that we don't have more mental health professionals involved in these evaluations. I think it's really, really a negative thing, really a scary thing. And vast majority of people have insurance. And actually, people often think it's financial burden. This is actually higher than it usually is. Usually it's under 10% report that the reason why they are requesting to die is financially. Much bigger reasons, losing autonomy, and not being able to engage in activities you enjoy, loss of dignity. Here's your burden, burdensomeness coming up again. Loss of control of bodily functions. Inadequate pain control also, not a huge percent, but this is one of those things that we can fix, we can control. Now, sometimes the pain is not controllable, but often that's something that can be addressed. So, just something to consider. But those are the basic stats about physician-assisted suicide. I haven't decided for sure if I'm going to have a message board topic on it, but I suspect I probably will. So think about what your stance is, knowing that there's not a right or wrong answer. Competent people can very easily disagree on these. They do. But I'll be interested to hear your thoughts on this. Should we have physician-assisted suicide? Should we not? Should we involve mental health professionals in doing these assessments, or should we not? So just things to think about, and I'll see you in the message board.